Welcome everyone to this week's NeuroCatch rounds. Today, Patty is going to be running the round. She works alongside Antonella at Helios and knows her best. And I'm really looking forward to having this session on PONS today. We've talked a lot about PONS in our past clinical rounds, and we've had a lot of people express interest in learning more about it. So without further ado, I'm going to hand off to Patty to go ahead and do the introduction, and then I look forward to a lively discussion. And thank you again, Antonella. I know you're crazy busy, so it's wonderful to have you. We're looking forward to sharing more about PONS with the network. We're huge fans, as you know, and looking forward to teaching more people about how it gets used in a clinical context and some of the amazing success stories that we've seen with this device.
Thank you for having me, and it's an honor to present to the audience.
Okay, well, thank you so much, everybody. I'm just going to take a few minutes here and tell you a little bit about Dr. Favit Van Pelt. First of all, I want to thank everybody for taking the time out of your busy day to join us for the 4th Brainovation Network clinical round. And as we've already said, today we're super lucky to have Dr. Antonella Favit Van Pelt, Chief Medical Officer at Helios Medical Technologies. She will be discussing the PONS therapy for neuroplasticity and balance and gait rehabilitation. So a little bit about Antonella. She is a rare disease expert and a pioneer in the field of applied theranostics for the development of disease-modifying treatments. As a board-certified neurologist, she holds a PhD in pharmacology and has more than 20 years of drug development expertise in the pharmaceutical industry and academia. She started her clinical practice activity in 1994 with specialist clinics in Europe, where she continues her involvement as a specialist consultant managing patients with movement disorders and rare neuromuscular disorders. Before Dr. Favit Van Pelt was the Chief Medical Officer at Helios Medical Technologies, she served as head of the U.S. Medical Strategy for Neurology at Lundbeck and head of medical affairs at Luitpold. In 2013, she founded Cenarion Therapeutics and its affiliate, Thera Neuropharma, 2 privately held biotechnology companies developing a small molecule regenerative therapy and RNA interference-based integrated technology platform for ALS and TBI. Dr. Van Pelt oversaw all aspects of the company's management and strategy as Chief Executive Officer, President, and Chairwoman of the board from 2014 to 2017, and she continues to serve as President and Chairwoman. In 2009, she founded Stratmedica, a privately held company designed to provide corporate clients with contract senior management support. Dr. Van Pelt directed clinical development and medical programs for several healthcare companies, including Johnson & Johnson and Teva. She started her pharmaceutical career in 2001 as Global Clinical Development Lead at GE Healthcare. And in 2005, she was Director of Medical Strategy at Bristol Myers Squibb. And in 2007, she became Senior Director and Global Medical Lead at Shire Pharmaceuticals. Again, thank you everyone for attending today, for your time. And over to you, Dr. Van Pelt. I'm going to go ahead and share your slides. Give me a second. Is that going?
All right. So thank you very much for the opportunity to present. As I mentioned, I'm honored, and I hope that my presentation would provide insightful information on a new therapy. So the portable neuromodulation stimulator, also known as PONS, is a new therapeutic intervention that leverages neuromodulation mechanisms to promote neuroplasticity for improvement of balance and gait deficit in people with certain neurological disorders. PONS is authorized in the United States and Canada for the treatment of gait deficit in multiple sclerosis, but is also authorized in Canada for gait deficit in stroke and balance deficit in traumatic brain injury. Furthermore, we also have an authorization in Australia for improvement of balance and gait in general. Next slide, please. So PONS is an orally applied therapy delivered through neurostimulation through a mouthpiece that is connected to a portable controller. The PONS device is an electronic pulse generator designed to promote cranial nerve neuromodulation, also known as CN and INM, and also known as translingual neurostimulation. Next, please. The PONS device consists, or should say the PONS system consists of a lightweight portable controller worn around the neck and a mouthpiece that has 143 gold-plated electrodes positioned to electrically stimulate the front top of the tongue. Next, please. Once activated, the mouthpiece sends electrical stimulation to nerve fibers in the tongue while performing gait and balance exercises. PONS therapy promotes neuromodulation, and when used regularly and consistently over a 14-week period, triggers neuroplasticity in a significant improvement of gait function. Next, please. The body of available evidence, imaging evidence, and clinical evidence across TBI and MS and stroke support the mechanism through which PONS exert a neuromodulation effect that leads to consolidated neuroplastic changes likely to be responsible for its therapeutic effect. And if we want to have the sound, it would be great. Patty, we need the sound for the video. I guess if you share, you need to stop the video and share the sound. Activate the sound when you share your presentation. So you need to unshare and then activate the sound and then share again.
That might be something that is just beyond my capabilities, Antonella, just a sec. So,
yeah, so if you stop sharing,
okay.
Then there should be a function that allows you to say,
Oh, I see.
turn audio.
Yes.
Right. Yeah.
Okay, hang on a sec. Let me share again. And go back.
And yes, please go back. Go back into the video.
The cerebral cortex.
Bring the
Sustained
video.
neuromodulation by PONS.
Okay, perfect. Thank you.
What?
We're good. We can hear it.
The tongue is innervated by branches of the trigeminal and facial nerves with direct connections to the brainstem. Clinical evidence suggests that using PONS therapy, PONS device plus physical therapy, can induce neuromodulation effects by the translingual stimulation of the lingual nerve, a branch of the trigeminal nerve, and the chorda tympani, a branch of the facial nerve. This stimulation promotes specific activation of targeted nerve centers in the brainstem and cerebellum, which are associated with movement and balance. This process activates mechanisms responsible for neuromodulation of signaling pathways from and to specific areas of the cerebral cortex. Sustained neuromodulation by PONS-induced activation of these cortical areas is likely to trigger, in these regions, a series of adaptive changes through a process known as neuroplasticity. The neuroplastic process is expected to rehabilitate existing pathways as well as engage new mechanisms that can deliver functional signals to the spinal cord. Consistent and repeated application of PONS therapy over 14 weeks is likely to consolidate these functional compensatory pathways and potentially lead to a sustainable functional improvement over the 14-week treatment period.
All right, I think we can advance this slide now. Let's go to the next slide. So in clinical trials, the PONS device was used while performing physical rehabilitation therapy according to a specific 14-week program designed to facilitate a regular and consistent treatment. Next. During the first 2 weeks, the patients performed their physical exercise every day, primarily in clinic, under the supervision of the clinical study rehabilitation therapist, and were encouraged to perform the assigned physical exercise training at least once at home, in addition to the in-clinic session. After the first 2 weeks, until completion of the 14 weeks program, patients performed the rehabilitation program independently at home, returning to the clinic once a week for data capturing and therapeutic process or exercise training adjustment. Next slide, please. Like every medical treatment, dosing is important in ensuring a meaningful therapeutic effect. Next. So if we look at the schematic, PONS is being administered for 20 minutes at each time when the patient performs balance training, gait training, and breathing and awareness technique training, mindful training. The patient is required to perform twice a day for a minimum of 100 minutes a day, up to 120 or even more, minutes a day. What we in clinical practice recommend is that patients are mindful of the fact that the efficacy of PONS therapy is closely related to a consistent daily therapy. And as I said, ideally 100 to 120 minutes of PONS device utilization with exercise and relaxation tasks. Now, this data are not going to be in the slide presentation, but I wanted to point out that we have recently conducted a preliminary analysis for the PONCEPT study. It's an outcome research study that aimed to look at the relationship between treatment adherence and therapeutic outcomes. And we have been able, through this study in the United States, across 6 centers of excellence, to confirm that patients who actually adhered to the recommended dosing of 100 to 120 minutes of PONS therapy achieved an improvement in the DGI of approximately 7 points. The minimum threshold to achieve a clinically meaningful and statistically significant improvement of 4 points was 70%. So as you can see here, there is a direct linear relationship between treatment adherence and degree of improvement with PONS therapy. Therefore, dosing is fundamental in how patients will respond to the therapy and how the therapy and what the therapy can do for patients. Obviously, a clinically meaningful improvement of 4 points in the DGA or FGA is important already, but an improvement of 7 points can make the difference between disability and ability in patients with gait deficit in MS. So, next slide, please. So PONS therapy is safe and well tolerated, and clinical studies and real-world evidence show that consistent application of PONS therapy for an average of 100 minutes per day results in clinically meaningful improvement in gait deficit in people with multiple sclerosis and stroke, and balance deficit in people with traumatic brain injury over the course of 14 weeks treatment period. Next. So in patients with a chronic balance deficit from mild to moderate TBI, PONS therapy has proven effective in improving balance deficit and, as a secondary endpoint, gait impairment after 2, 5, and 14 weeks of treatment. Next. In TBI participants treated with the average dose of 100 minutes a day, the sensory organization test, the composite score, which measures balance deficit improvement, increased on average by 23 to 25 points from baseline. Approximately 63 to 71% of the patients responded to treatment after 5 and or 14 weeks. I need to premise that this study was intended to be comparative between a high-frequency stimulation device and a low-frequency stimulation device. As you can see here, we did not achieve, unfortunately, by a smidge, clinical significance, statistical separation between the two groups. But what is really important is that, you know, the degree of separation from baseline, significant intra-group, statistically significant separation. So dynamic gait, next please. In addition to the SOT, also dynamic gait index scores, which measure gait deficit improvement, were increased by an average of 4 points from baseline after 5 and or 14 weeks of treatment. This is important because it speaks as to the consistent degree of improvement that we observe in patients with gait deficit across all disorders, as I will show you later. And this is a correlation with the mechanism of action of PONS. And that suggests that PONS exert a central effect, upregulating centers that control movement and coordination, regardless of the underlying condition. Next slide, please. Next, please. So in a long-term PONS therapy trial, the therapeutic effect on balance and gait was reached after 14 weeks of active PONS therapy was also maintained for an additional 12 weeks post-treatment. So this is the first evidence of durability of effect. The PONS STEP study that is still ongoing in the United States, in addition to the 14 weeks treatment phase, also has a 6 months durability of effect, so follow-up phase, that we will be analyzing at the end of the year for durability of effect. Most importantly, during the 6 months, we're going to also analyze the percentage of patients who have declined more than 30% that have required a retreatment with PONS. This data will be available early next year. So the study will complete at the end of the year, and the full study results will be available at the end of next year. So next slide, please. In a health economics study sponsored by Canadian Pacific Blue Cross and performed by Italian colleagues, 9 chronic mild to moderate traumatic brain injury subjects with balance or gait deficit on total and permanent disability were treated with 14 weeks of PONS therapy. Occupational performance and return to work were measured as the primary treatment outcomes. All participants showed improvement of their balance and or gait deficit. In 80% of participants, balance or gait deficit no longer represented a barrier to work. 50% reported improvement also in other disabling clinical outcomes, including headache and mental health concerns. Next, please. So next, as a result of PONS therapy, 50% of the participants returned to work or had been deemed work ready, and their disability file was permanently closed. 80% of those who returned to work remained on full-time with full duty activity throughout the 6 months study observation period. All participants reported excellent improvement in satisfaction in their perception of performance on self-care, productivity, and leisure activities. Next, please. The cost effectiveness of PONS therapy was estimated at 52% reduction, approximately 2.3 million of the overall 4.4 million long-term disability cost for all participants. Next. I'm going to show you some evidence, clinical evidence in stroke. A randomized clinical trial in stroke patients showed a statistically significant effect of PONS therapy in improving balance deficit after 2 weeks of intense physical therapy rehabilitation with PONS as compared to high-intensive physical therapy alone. Score on the mini-BEST, which measures gait and balance deficit improvement, was 22.9 in the PONS-treated group as compared to the 13 in the control group, providing a clinically significant and meaningful therapeutic outcome. This result is particularly important if considering that a 17.5 score on the mini-BEST assessment has been shown to discriminate between faller and non-faller in patients with more than 6 months chronic stroke. Next, please. Also, a real-world evidence analysis of clinical gait as measured by the functional gait assessment test in 31 stroke patients showed that 69.2% of patients experienced at least a 5-point increase in the FGA score with an average improvement of 6.74 over 14 weeks, indicating that 51.5% to 87% of stroke patients would experience an improvement of gait higher than 4.5 FGA points. Next. Furthermore, out of 25 subjects at risk of falling, as determined by the FGA lower than 23 at baseline, 28% of subjects were no longer at fall risk by week 14. A result of particular significance since physical therapy alone provides a meaningful shift in the risk of falling only in 1 to 3% of stroke patients. Additionally, the one subject who was not at fall of risk at baseline remained fall-free at week 14. Next. So these are studies on MS. So this is a clinical trial, and I'm going to present a combination of clinical trials and imaging in the same slide. In a double-blinded clinical study, patients with gait deficit due to multiple sclerosis treated with the recommended average dose of active PONS therapy of 100 minutes a day, 100 to 220 minutes a day, experienced a statistically significant improvement in gait measured by the DGI as compared to physical therapy plus a sham device. Next. Next. In the sham group, only 30% of the subject reached a 4-point improvement from baseline to week 14, and the mean average DGI improvement for this group was 3.45 points. However, such the improvement declined after 8 to 10 weeks of physical therapy. Now, you see on the top a representation of the imaging data that show that physical therapy was did not activate additional cortical areas other than the premotor cortex, which was already, activated at baseline in both the control and the active group. Next, please. In the active group, PONS therapy led to a statistically significant improvement DGI score at least 4 points from baseline to week 14 in all treated subjects. Next, please. As you can see here, the improvement started at week, just right after the 2 weeks of in-clinic at home, so the combined in-clinic at home therapy. And during this, this 14 weeks, we could see during the first 2 weeks, we believe that neuromodulation processes would start the mechanisms that would lead to the next, please, to the neuroplasticity changes that we have observed at 14 weeks with PONS therapy, meaning, as I explained, as the video explained earlier, that PONS therapy leads an activation of the dorsolateral prefrontal cortex bilaterally, the right anterior cingulate cortex, and the left motor cortex. This is unique to PONS therapy as this activation was not observed in the placebo. But I also say anecdotally that none of the current therapies, including transcranial electrostimulation, have shown to have this activation pattern. This has been observed both in MS patients and TBI patients, further supporting the possibility, the hypothesis that PONS therapy upregulates brain mechanisms, specific and selective mechanism of gait and balance control, regardless of the underlying condition. But what is more important, next please. All participants, so participants reached almost 8 points of, between 7 and 8 points of improvement by week 10. And what is important is that during the remaining 4 weeks of treatment period, this effect was maintained. Further support the fact that by week 10, the neuromodulation and neuroplastic process is completed, or at least I would say the adaptive changes process is completed, and the additional 4 weeks are needed to consolidate the neuroplastic changes that have occurred during the treatment phase, during the whole 14 weeks treatment period. This is very important because, as you could see here, patients who are in the sham group, they started to decline while continuing their physical therapy from week 10 to week 14. So this is now next slide, please. Next, please. Real-world evidence database analysis of gait-impaired MS patients showed a mean improvement in the FGA scale of approximately 4.63 points from baseline to week 14, which was also statistically significant at each time point. So at 2, 4, and 8 and 14 weeks. In addition, the percentage of subjects who achieved at least 4 points improvement in the FGA increased over time and reached almost 60% at week 14. Next, please. The pool analysis that we done, combining the real-world evidence and the clinical trials data, showed a mean improvement of DGI of approximately 5 points from baseline to week 14, with 55% of subjects experience a DGI improvement for baseline greater than 4 points. As you can see here, both clinical, the real-world evidence closely mirror the improvement that was observed in the clinical trials. And again, as you've seen from the other, the clinical data from the other disease states, this improvement is consistent. So the amplitude of effect, the effect size of this improvement is consistent. And as a matter of fact, we've done some further analysis and to prepare for a registrational program in stroke, which is currently in the States and in Canada. And we have, in doing our sample size calculation, we calculated through the database that PONS has an effect size of 1.5, which in the world of drug development and non-pharmaceutical development is extraordinary, given that the average of separation in effect size between an active and a study treatment and a control group seldom exceeds 0.5 or in the effect size. So we actually have consistently an effect size above 1 and between 1 and 1.5. That speaks as to the fact that regardless of how you use PONS, if you have balance and gait deficit across stroke, TBI, and MS, you can expect the same type of therapeutic outcome in your patients if the patients are, consistently using the therapy between 100 and 100 minutes a day. Next, please. So PONS therapy has a very favorable safety profile. Overall, the therapy is safe and well tolerated with a low rate of reported adverse events in clinical trials, which are mild and often related to baseline comorbidity and not PONS treatment. Next, please. In the MS and TBI randomized studies, there were no serious PONS device-related adverse events in any disease group. Also, a reduction from baseline in false rates and adverse events and headache adverse events, as well as improvement in sleep quality, were reported in the TBI subject. Similarly, in the stroke trial, no serious device-related adverse events were reported for any subject treated with PONS therapy. Next, please. Since early 2019, PONS has been used in over 480 patients in clinical rehabilitation settings to treat balance and gait disorders, with more than 180,000 patient sessions recorded. An exhaustive search of complaint records for 33 patients with a diagnosis of stroke yielded a total of 13,960 patient sessions with no serious device-related events recorded and no reportable adverse events. Next. So in conclusion, we could say that the clinical correlation that PONS neurorehabilitation approach target complex functional system for control of balance and gait. The clinical correlation with the presumed mechanism of action indicates that PONS therapy can mitigate deficit and improve function through neuroplasticity. Next. Translingual is likely to upregulate brain activation with a shared mechanism independent from the etiology of the underlying condition by directly modulating the neural pathways responsible for movement and balance. Next. PONS therapy, and this is the innovation, PONS therapy engages alternative compensatory pathways in the brainstem that recover neural mechanisms needed for control of gait and balance by modulating concomitantly multiple brain regions. Next. PONS therapy significantly improves dysfunctional gait and balance in patients with TBI, stroke, and multiple sclerosis. The body of evidence from clinical study and real-world evidence database in patients with gait or balance deficit due to these neurological disorders, next, demonstrate a consistent gait average gait improvement above 55% in the FGA, at least 5 points from baseline, and DGI score, at least 4 points from baseline, across all medical conditions studied. Next. So this is just the next, please. These are the references, the support our clinical data. Next. Next. And thank you so much for your attention. I'd be happy to answer any questions.
Thank you so much, Antonella. I'm going to just take a look here. We have a question. Are there data comparing PONS with PT and PT alone?
There's no data comparing with PT alone, but you have to remember that the sham device that we use in our clinical trials do not deliver any stimulation. So it's the equivalent of having PT alone. So there was data in stroke were done with PT alone without the sham devices. So you could see that for TBI, we had a low frequency device. For MS, we had no frequency. And for stroke, we had PT alone. And the response is consistently across. It's very consistent across.
Rossi, I'm not able to see all of the participants. Is there anybody that would like to be unmuted so that they can ask a question? Or...
we do have one more question.
Oh, I do see that.
It's from Sam Levy. And what is the reason for the recommendation that movement control exercises be performed without PONS?
I'm sorry, you're breaking up. What is the question?
Okay, Sam, can you unmute here? I can unmute you or not. Okay, we'll try Sam, if you want to ask your question.
Yeah, are you able to hear me?
Yes, I can hear you. Yes.
Perfect. I was wondering what the reason was for the recommendation that movement control exercises be performed without the use of the PONS device.
Well, that has a lot to do with the mechanism of action. And if you can see, I mean, we could go into more details, but translingual stimulation activates the pons in the medulla and region and the trigeminal nuclear pathway. So the vestibular trigeminal pathway in the cerebellum, which are responsible, these are the structure responsible for control of movement in the brainstem. The important thing is that the brainstem alone is not engaged, but it's complemented by the concomitant activation of cortical areas, like especially the cognitive centers that regulate gait and balance. So it's the entire pathway, the entire mapping of this pathway that is responsible for the therapeutic outcome. Obviously, if you want to improve a function, you need to perform that function that you want to improve to to trigger the upregulation of this areas. So the point is different than when you use a TENS device. A TENS device is a peripheral stimulation, so sends inputs from the periphery to the brain. PONS works exactly the opposite. You perform the movement you try to perform a movement in a function that is impaired. PONS stimulates the brainstem and the cortical to upregulate those mechanisms that regulates that movement from the brain to the periphery. And therefore, so let's say that you have, we have studies where we have looked at PONS activation. So imaging study that we looked at PONS activation without physical therapy. We still see activation of the dorsolateral prefrontal cortex and the right anterior cingulate cortex. But what we don't see is activation of the left motor cortex. So while we believe that technically, if you don't perform, any function and you are just cognitively challenged or cognitively engaged, you can still see activation. In order to get improvement in gait and balance, you have to perform the function, because that performance of the function is what's going to activate, increase bold signals in the left motor cortex and further engage the dorsolateral prefrontal cortex and the right anterior cingulate cortex.
Okay, yeah, I think if it's all right, I think if I could clarify my question a little bit, I entirely agree with you that absolutely doing, engaging in physical therapy while you're using the PONS device is what's going to lead to those outcomes that you're desiring. If the movement control exercises that you're performing are being done to, add to the balance and the gait actions that you're trying to do while you're doing balance and gait training, let's say that's strengthening certain muscle groups, would it be beneficial to be using the PONS device while you're doing those exercises, even if it's falling outside of the balance or gait?
Okay, I see what you mean. You're saying that we recommend a certain set of exercises to do during your rehabilitation with PONS. What you're saying is that if I use PONS outside of the recommended physical therapy training, right, would that be beneficial? Or in place of? So we do not have data that show that PONS will be beneficial if you use it in place of the recommended exercise. Mechanistically, though, one would need to establish whether, in addition to performing the exercises they're recommended for PONS therapy, if the patient uses it and continues to use it in addition with other movements, the therapy as additional benefit. We have no data, but we also have no reason to believe that if you add you would not, I mean, you would not have an, an improvement. Now, I cannot comment to you whether this improvement would be additional, so you would have a better outcome, because we don't have data. But there's no reason to believe that using PONS during exercise while doing exercise is not going to lead to some form of therapeutic benefit.
Great, yeah, that answers my question. Thank you. It was more so if there was any reason to not be doing that in addition, as you mentioned.
Yeah, we don't have data though that shows that if you do it, you have an incremental, effect, but there's no reason to believe that it shouldn't be effective.
I like your careful answer, Antonella. That was very good. I don't
Well,
see
I mean, we speak through evidence. I mean, this is one thing that at Helios, I really, really, really make sure that everybody is attentive and follows. I would recommend everyone not to offer information about our therapy that is evidence supported.
Absolutely. I don't see any other comments or questions in the chat. I don't think.
Is it all right if I ask another question or two? If no one else has any questions, of course.
Absolutely.
Yeah, so one of my other questions as well was, I know that there's that recommendation of how many minutes to perform each different session, and that includes the breathing and awareness training. I was wondering specifically what some of the value of that was in being included in the training, how you promote the benefits of that. If you do have, I know it's, with clinical trial, you maybe don't have to do that so much, but what would your reasoning be for the importance of including that on top of the balance and the gait training?
So this is a very important point. Thank you for raising it. So the breathing and awareness training is fundamental in consolidating the learning that the brain is developing during treatment of balance and gait. So remember what I said. Remember that I mentioned dorsolateral prefrontal cortex and anterior cingulate cortex. Those are the cognition, the areas that control gait and movement from a cognitive standpoint. So that cognition is important. So what happens is, as you neuromodulate the brain, as you stimulate the brain to rebuild this network of pathways that has been impaired in multiple sclerosis, for stroke, TBI, what happens is once you do the exercise, you need to consolidate the learning. So you need to have time for your brain to absorb, right, what this stimulus. So for the brain to consolidate the process, the neural process that is slowly reorganizing the impaired pathway. So this is essential because it plays into the cognitive element of the therapy and consolidates, help consolidating these changes into a reorganization pattern. So it is really important because it says, okay, it's like learning something. You learn, you need to learn a new language, for example, right? And if you only, just read it, or if you only just watch, with the captions, but you don't practice, right? Go back and rethink of what you've learned, you're never going to learn. So when you have, sometimes this is one of the reasons why at school they had you read and then the next day you need to engage and repeat, because it's a process of consolidation. The same thing goes for movement. You need to consolidate what the brain is learning through this different pathway. Remember, this is really important. PONS therapy do not act through the physiologic mechanisms of gait control. We engage a compensatory mechanism. It's an alternate mechanism, which is the vestibular trigeminal pathway. So the brain normally doesn't respond to that, doesn't engage that pathway to control movement. So now it's learning to use that pathway. But if you don't give the time, the brain the time to consolidate what they learned from the movement, you're not going to, have a durable.
Yeah, that makes sense. Thank you. When someone is doing that breathing and awareness training, do you ever kind of prompt them in order to really facilitate that consolidation? Do you prompt them to rethink about the stuff that they've already learned, or is it more passive? They just go through that that training?
So it's actually both. I mean, technically it should be done immediately after, so you don't really have to rethink because the brain is already thinking, right? So consciously we might not be aware that the brain is still processing this information, but the brain is. So if you do it and you let the stimulation, so you let this electrical stimulation going, you don't need to think. So some of the things that some patients would do gait and balance. This is the 100 minutes. I'm going to explain this in the 100 minutes. Some people would do gait exercises, 20 minutes of gait exercise in the morning, 20 minutes of balance exercise in the morning. Then they will repeat, they will not do the BTA. They will repeat it in the evening and then do the BTA in the evening. In that case, it would also help if they have some gait imagery performing while they are doing a gait relaxation. So if they, have some images in their brain of moving, not necessarily redoing, reprocessing the exercises, but what's called gait imagery, images of them walking around or riding a bike. So that's what we do. If you do it twice a day, so it probably you just can relax. But if you do it only in the evening, it might help to have gait imagery, to reprocess gait, with gait imagery.
Great, awesome. Thank you so much for that answer. It's really helpful.
Sure.
I do have one more question.
You go.
My last question was just if you do have someone who maybe struggles a little bit with fatigue, and obviously the recommendation is 100 minutes per day. If they feel that doing that 7 days a week perhaps is a little bit too much, and they're finding that that's impacting their ability to complete sessions to the best of their abilities, would you ever recommend a day or potentially even 2 off?
So here's how PONS therapy is applied in real world clinical practice. So first and foremost, each patient is different. So the PONS trainer is not necessarily someone who just learned how to use PONS. The PONS trainer is someone who's first and foremost a rehabilitation specialist. So you need to gauge your patient ability to perform. So not every patient is going to be able to do, like 100 minutes on day one. And that's not even the purpose of doing 100 minutes. That's the importance of those first 2 weeks. And that's the reason why we ask these 2 weeks to be combined clinic and at home. Because these 2 weeks help the brain start their neuromodulation process. So it helped the patients grow into the therapeutic regimen. So there's patients who can just say, okay, do what you can. Try to use it twice a day, but maybe you just don't do the exercises as strenuously. What is really important is the patient keeps the stimulation for all the 20 minutes. And even if they have to take a break, they continue to have the stimulation ongoing. The stimulation is what really, PONS, the stimulation is the therapy. So for example, you have a patient that starts for the first, in the first week and is unable, to complete their exercises. As long as they do the 20 minutes and they do what they can within those 20 minutes, that is what's important. Now, obviously, if the therapy is working, then you will see a gradual improvement. And as you can see in the data that I've showed you, especially in MS, you have, the first week to reach 4 points, but you don't reach 4 points in day 2 and day 3. You reach 4 points after you've been able to also build endurance in your patient. So your patient is able, that's why you want to see him in clinic as often as possible and would encourage them, in clinic. So you don't necessarily have to start with 100 minutes on day 1. your goal is to get this patient to be able to do 100 minutes relatively quickly, but that's also aided by the fact that if the therapy works, the patient is going to be able, because the therapy is going to make them able to do this.
Great. Thank you for your time. I've got no more questions.
Those were excellent questions, Sam. Thank you very much. And I just want to let you know that although Antonella has done a fabulous job of answering some of your therapy-related questions, in the new year, we will have 2 clinicians that probably have the most hours of therapy with patients in the world. And they will be doing a session on gait and balance rehab, and they will be talking about PONS and their experiences. So look out for that one as well. Okay. Well, unless we have anyone else that has a question, I think that we're done. Antonella, Dr. Favit Van Pelt, I want to thank you again for your time. This was a fascinating session. And if anybody has any questions at all for Dr. Van Pelt and Favit Van Pelt, and you don't have them right now, you know that you can send them to our info Brainovation email address, and we will have those answers for you. So thank you so much, everyone. And with that, I will say goodbye for the group.
Thank you. Bye.